Good evening and welcome to tonight's tutorial. Can you hear me?
Yes, Prof.
Yes, Prof. Can hear you, sir.
Yes, Prof.
All right, so we'll be looking at a very important topic in the ICU, acute kidney injury. All right, and as usual, these are learning outcomes, okay, and we'll follow this outline. So let's quickly answer these questions, like our practice. So a 65-year-old male patient with sepsis from community-acquired pneumonia is admitted to the ICU. His serum creatinine was 1 milligram per DL on admission. However, on day 3, the serum creatinine increased to 2.2 milligram per DL. In addition, his urine output over the last 12 hours has averaged 0.4 ml per kg per hour. So which of the following best describe his current kidney function using KDIGO criteria? A, no AKI. B, AKI stage 1. C, AKI stage 2. D, AKI stage 3. E, chronic kidney disease. Any answer? Hello? Anybody? Can you hear me, guys?
We can hear, sir.
Okay. Any attempt?
I'll choose B, AKI stage 1, sir.
Okay, what's the basis?
The
Support your answer.
The urine production should have been at least 0.5 mils per hour every hour. However, in the last 12 hours, it averaged 0.4 mils. Then again, there has been a slight increase in the serum creatinine, but I'm not used to, I can't remember the range of, I think the first range, creatinine should increase up to 26 micromoles. So it's just a guess. It's just a guess.
Okay, I like your sincerity. It's just a guess. Any other attempt? Any other attempt at this? Okay. Is it that we're not familiar with the KDIGO criteria? Okay, I think so. Okay. We'll answer that, but the answer is true. Okay, C. AKI stage 2. Okay, let's look at this second question. A 72-year-old woman admitted for ruptured abdominal aortic aneurysm. Aneurysm repair develops AKI on post-op day 1. Her urea output has dropped to 200 mils in 24 hours, and her serum creatinine has increased also from 1.1 to 2.5 milligram per DL. She's hypotensive, presently on vasopressors, and her CVP is 14 millimeters of mercury. So which of the following is the most likely cause of her AKI? A, hypovolemia. B, acute tubular necrosis. C, obstructive uropathy. D, contrast-induced nephropathy. E, glomerulonephritis. Anybody? Any attempt? Please talk. Don't just put on the chat so that we can have a discussion. Any attempt?
C.
Sorry?
C.
Not correct. Any other attempt? Look at the question. We agree that there's an AKI, isn't it? All right, but the patient is hypotensive, even though the CVP is high, is 14, so it can't be hypovolemia.
B.
Sorry?
B.
B, correct. B, correct. Patient is on vasopressor, all right? And most likely have been hypotensive for some time because of the abdominal aortic aneurysm. So there's some acute tubular necrosis that is taking place there. Okay. Question 3. A 55-year-old male patient with multi-organ failure from severe pancreatitis is admitted in the ICU. Despite adequate fluid resuscitation, his creatinine is 4 milligram per DL, potassium is 6.8 millimole per liter, pH is 7.13, with bicarbonate of 12 millimole per liter, and is oliguric for 24 hours. So which of the following is the most appropriate next step for this patient? A, increase IV fluid. B, administer furosemide 80 milligram IV. C, begin intermittent hemodialysis. D, start potassium binders. E, observe and repeat labs in 6 hours.
I think he should have straight hemodialysis, actually, sir.
Sorry?
C, sir. I think he should have hemodialysis, sir, because of the metabolic acidosis, sir, and the hyperkalemia, sir.
Okay. Any other answer? Any other different answer? Or do we agree with him? My people are quiet today. What's happening?
Hello, sir. I also support C because the patient is having acidosis and we have hyperkalemia. I think C.
Agreed. So C is the correct answer. Correct. Okay. Question 4. A 38-year-old woman with pneumonia-induced AKI is on IV vancomycin and meropenem. She's oliguric with a creatinine of 3.5. Which of the following best describes the pharmacological consideration for antibiotic therapy in AKI? A, increase vancomycin dose to overcome resistance. B, continue standard dosing until urine output improves. C, adjust dose of vancomycin based on trough levels and renal function. D, reduce meropenem dose to once every 72 hours. E, stop antibiotics to reduce nephrotoxicity.
Or C.
C.
Adjust dose of vancomycin based on trial levels and renal function.
Okay. Any other question? Any other answer? Or do we agree? Anybody to support or to disagree with that answer?
Agree with C, Prof.
Support and agreed.
Beautiful, beautiful, good. Vancomycin is one of the drugs we need therapeutic monitoring for, okay? TDM. So you want to adjust the dose based on trough levels. Okay. Question number 5, a 55-year-old patient, ICU patient after cardiac surgery, has stable urine output but a slight rise in serum creatinine. You suspect early AKI. Which of the following biomarkers may provide the earliest indication for AKI in this patient? A, serum creatinine. B, blood urea nitrogen. C, urine output. D, neutrophil gelatinase associated lipocalin. And E, fractional excretion of sodium. Any attempt?
E.
I didn't hear E or A.
E for egg.
Okay. Any other answer? Or any support for that answer? Hello?
A.
Well, the two answers are not correct. Any other attempt?
B. Of urine output, most likely.
C.
Yeah. The answer is D. All right. The answer is D. Is the earliest biomarker for AKI. Okay. All right. Good attempt. Hopefully, we'll understand better some of these answers as we go on. Now, the first thing is are these questions?
Take E because
I can't hear you fully. You are breaking. I can't hear you.
Quickly.
What were you saying? Hello? Okay, let's go ahead. I didn't get that. All right, so let's quickly go into the discussion today. Let's look at, remind ourselves about the kidney. All right, the structure of the kidney, as we can see. Each kidney is a bean-shaped organ located retroperitoneally. Grossly contains the renal capsule, which is the top fibrous outer covering, the cortex, the medulla, and the renal pelvis. The renal pelvis is the funnel-shaped structure that drains urine into the ureter. Microscopically, the nephron is the functional unit of the kidney, approximately 1 million nephrons per kidney, and comprises the glomerulus, which is for filtration, Bowman's capsule, the convoluted tubules, both the proximal and the distal. The proximal is for reabsorption, while the distal is for fine-tuning of electrolytes. We have the loop of Henle for urine concentration, and we have the collecting duct where final urine concentration takes place. Okay, so functions of the kidney, a wet bed. Just to remind you, the kidney prevents a wet bed, okay? So A, acid-base balance. You know, the kidney functions for water balance, electrolyte balance. C for toxin removal. All right, blood pressure control via the renal, the RAS system. All right, E, erythropoiesis to stimulate red blood cell production, and D, vitamin D activation. So these are some of the functions of the kidney. All right, so this is just the diagram of the kidney. So renal physiology, the kidney receives about 20% of the total cardiac output, and blood supply is through these 8 different arteries and arteries, okay? Renal artery, interlobular artery, acute artery, and blah, blah, blah. So one thing we need to talk about now is the glomerular filtration rate, all right, which depends on the interplay between hydrostatic pressure and aquatic pressure within the kidney. So the hydrostatic pressure is usually greater in the glomerulus than within the tubules, which causes filtrates to be, to come out of the capillary bed into the tubules. The aquatic pressure, on the other hand, is generated by the non-filter proteins, which helps to retain fluid in the intravascular space. So glomerular filtration rate, therefore, is Kf, which is the constant, multiplied by the hydrostatic pressure minus the aquatic pressure. Normal glomerular filtration rate is about 100 mils per minute per 1.72 square meters, all right, the surface body area. So, excuse me. AKI, not formerly known as acute renal failure, represent a spectrum of diseases which range from subclinical renal injury to complete renal failure. All right, it's very common in the ICU and is associated with increased mortality. All right, mortality rate of AKI in the ICU is usually above 50%. Okay, 7% of all hospitalized patients will develop AKI, and 36 to 67 of all critically ill patients usually come down with AKI. So this is how common AKI is for our patients. All right, usually occurs over a few days and initially often reversible, but it can also is a major cause of death during acute illness. Note that it may develop with or without pre-existing renal impairment, as it may follow any severe acute illness, trauma, or major surgery, especially those involving the heart and great vessels. So surgery in the presence of liver impairment, obstructive surgery, and any condition involving hypertension, which usually predispose patients to AKI. So according to a study in 2015 of about 279 ICU patients, the incidence of AKI was found to be very high, about 3%, irrespective of whether the patient is a trauma or non-trauma patient. The presence of AKI increases mortality in the ICU by as much as 10-fold, all right? And its incidence in the ICU was associated with older age, history of diabetics, higher length of stay in the ICU, use of invasive mechanical ventilation, and vasopressor therapy. Okay, so by definition, AKI refers to an abrupt or sudden decline in kidney function, all right, which will lead to fluid, electrolyte, and acid bed imbalance resulting from reduced glomerular filtration rate. And that's why we went through all those physiology. So when we say the patient is oliguric, that means that it's making less than 400 ml of urine per day or less than 17 ml per hour. And this is important. We are not going to wait for a whole day to declare a patient to be oliguric. So it's important. Any patient that is making less than 17 ml per hour, all right, should actually point us to an early AKI. All right, urine output also, which is less than 0.5 ml per kg per hour for at least 2 hours. Okay, all right, and that's why it's important for us to monitor our patient hourly in the ICU. When a patient is making less than 50 to 100 ml per day, all right, we can say the patient is anuric, not until when there is complete anuria. All right, so it's important for us to look at the relationship between GFR and serum creatinine. And if you look at this graph on the left side, you'll see that as the GFR decreases, all right, on this side, on this red line, from the normal 120 to 60, the serum creatinine increases. So this is a non-linear relationship, okay? And but it becomes very significant when it falls below the critical value of 60 ml per minute. So in early stages of kidney dysfunction, you can see that serum creatinine may remain normal, all right? You can imagine from 120 until it gets to 160 when serum creatinine begins to increase. So this is why serum creatinine cannot be used as an early marker of AKI, okay? So this is important for us to just remember. In as much as we use serum creatinine, it is not an early marker, it's actually a late marker of kidney dysfunction, and therefore cannot reliably detect early declines in renal function. There are different criteria that has been developed for the diagnosis or for the definition of AKI, and the first one as early as 2002 by the Acute Dialysis Quality Initiative is the RIFLE criteria. I'm sure many of us are familiar with this. All right, the RIFLE criteria categorizes AKI into 2 sessions. talking about the grades of severity and the outcome of AKI. All right, so based on grade of severity, we can have the kidney that is at risk, all right, with a creatinine increase, all right, of 1.5 above base level, okay, or urine output that is less than 0.5 ml per kg per hour in the first 6 hours. The kidney is, all right, there's kidney injury when there's 2 times increase in baseline serum creatinine and urine output has progressed, all right, less than 0.5 ml per kg per hour to 12 hours. We see the kidney has failed when we have an increase, baseline increase of creatinine more than 3, or when you have an absolute value of more greater than 4 milligram per DL, and urine output has dropped to 0.3 ml per kg per hour in the first 24 hours. In terms of outcome, we have a complete loss of renal function. All right, if all of this takes place for more than 4 weeks, and we have the end stage kidney disease, all right, when it's greater than this. So the RIFO criteria is one of the earliest criteria for definition and diagnosis of AKI. Then we have the acute kidney injury network, which was from international collaboration of nephrologists and intensivists. And the ACKIN criteria defined AKI as an abrupt reduction in kidney function, which is defined as either an absolute increase in serum creatinine, okay, of more than 0.3 milligram per DL, or more than 26.4 micron per liter, or a reduction of urine output of less than 0.5 ml per kg per hour for more than 6 hours. Note that the ACKIN criteria classifies AKI only after adequate fluid resuscitation. Okay, it also assumes a baseline creatinine is known. Okay, because that is the only way you can know the increment. Okay, and know that ACKIN criteria must occur within a 48-hour window. All right, so you must be able to categorize your patients based on the ACKIN criteria within 48 hours window. All right, so comparing the RIFO and the ACKIN criteria and the original RIFO criteria, GFR values were listed as reference, but these do not precisely agree with changes in serum creatinine like we saw in that nonlinear graph that I showed you. For the ACKIN network, the change in serotonin creatinine from baseline follows RIFO with an additional option to use 0.3 milligram per DL increase if this is observed to occur within the 48-hour window period. Then we have the KIDCO, or some people call it KDIGO staging. All right, KDIGO is the Kidney Disease Improving Global Outcomes, all right, which is a work of Acute Kidney Injury Work Group. You know, it has also developed, guidelines, clinical guidelines for management of AKI. So the KDIGO combines and refines both the RIFO and the ACKIN criteria, and it emphasizes early detection of AKI and staging to guide monitoring and intervention. Both serum creatinine and urine output are both essential for this, and we can have stage 1 to stage 3. So stage 1, using the KDIGO, is when there's an increase in baseline serum creatinine by more than 0.3 milligram per DL within 48 hours, all right, or there's an increase in baseline between 1.5 to 1.9. So any increase in baseline creatinine less than 2, all right, shows stage 1. So above 2, baseline above 2 but less than 3, all right, it's stage 2. And anything above 3 times above the baseline, all right, or you have a creatinine 4 milligram per DL, greater than 4 milligram is stage 3. So it's easier to know this. Stage 1 is increment less than 2 from baseline of serum creatinine is 1, stage 1. Between 2 and less than 3 is stage 2. 3 and above is stage 3. And this is essential because it helps us to make an early detection of AKI and also to stage it in order to guide monitoring and intervention. All right. So AKI etiology, it could be pre-renal, all right, or renal or post-renal. So pre-renal AKI accounts for 30 to 40% of all cases of AKI, all right, and usually resolves once the underlying disorder is treated. Some of the common causes of AKI resulting from decreased renal perfusion is hypovolemia, which can be hemorrhagic or otherwise, okay, or GI losses, decreased cardiac output, systemic vasodilatation from your sepsis or anaphylaxis, renal artery stenosis or thrombosis, which leads to reduction in renal perfusion, or some drugs, for instance, your non-steroidal ACE inhibitors. All right, these are some of the drugs that can cause reduced renal perfusion, leading to pre-renal AKI. Then we have the renal AKI of the intrinsic. This is due to damage to the kidney itself, and this is responsible for 50% of cases of AKI. All right, causes include the acute tubular necrosis, which is as a result of ischemic or nephrotoxic injury, acute glomerulonephritis affecting the glomeruli, acute interstitial nephritis, which is often drug-induced or due to infection. We will have vascular causes like your malignant hypertension or vasculitis, or it could be pigment nephropathy from rhabdomyolysis and hemolysis. So these are some of the things that can cause direct injury to the kidney. Then we have the post-renal, which is obstructive uropathy, which is responsible for about 10% of all cases of AKI. No, the renal stones really will cause post-renal AKI except the patient has only one kidney. So obstruction can result from stones. It can be due to enlarged prostate, tumors compressing urinary tract, urethral strictures, all right, especially from recurrent, UTI or STIs, okay? And this diagram shows the different portions where obstructions can take place. Okay, so mnemonics, for those of us who like mnemonics, for AKI, just remember pyrates, okay? P pre-renal, hypovolemia or heart failure, I intrinsic acute tubular necrosis or AGN, renal artery stenosis, acute interstitial nephritis, toxins, emboli or vascular causes or stones, okay? So these are some of the causes put together as mnemonics for you, all right, so that you can easily remember the causes of AKI. Okay, this is just another diagram to show you. Okay, what are the risk factors for AKI? All right, remember chronic D, patients with chronic kidney disease that falls acutely ill or injured, especially patients with estimated GFR of less than 16, all right, at high risk of developing AKI, patients in heart failure, hypovolemia, hepatic failure, patients with history of renal impairment. When you have oliguria, all right, or obstructive uropathy, neurological or cognitive impairment, which may limit access to fluid because of reliance on a carer, infection or sepsis, use of contrast, especially iodine-based media, all right, within the past 1 week, drugs that can cause or exacerbate drug injury, patients who are diabetic, and elderly patients aged 65 years and above. So these are some of the risk factors of AKI, and this is important because when you have your patient in ICU, all right, or patient going for surgery, and any of these risk factors are present, you have to look out for AKI developing in the course of managing this patient. All right, so some common causes, like we showed before, The most common causes in the ICU are sepsis, the 4S, sepsis, major surgery involving the heart and major arteries, shock, all right, there's the local apostate, substances, especially your drugs, nephrotoxic drugs. Other causes are what we've talked about here, patients with underlying liver impairment, trauma, patient who has undergone CP, cardiopulmonary bypass, patients with abdominal compartment syndrome, and patients with abdomyolysis. These are some of the common causes of AKI in the ICU. Now we need to talk about AKI, new AKI biomarkers, and this is important because of the non-specificity of serum creatinine and urea in the prompt detection and monitoring of progress of AKI. So these new biomarkers are very important. They reflect kidney stress, injury, or inflammation, and are especially useful in high-risk patient settings. So we have the neutrophil gelatinase associated lipocalin, the NGA. All right, this is actually released from damaged tubular epithelial cells, and it can be detected in the urine within 2 to 4 hours of injury. All right, so it's usually useful for early detection of ischemic or nephrotoxic AKI, and usually also predictive of the severity of AKI. Then we have the cystatin C. This is usually produced by nucleated cells that are filtered by the glomerulus. They are usually detected in the urine, and is more reliable than creatinine in some patients, especially elderly patients who are muscle wasted, and detects changes in glomerular filtration rate earlier than your urea or serum creatinine. Then we have other biomarkers like the kidney injury molecule, KIM1. This is expressed in proximal tubules after injury detectable in the urine, and it's useful because as it distinguishes ischemic or toxic AKI from pre-renal azotemia. All right, it's important because it's expressed in the proximal tubules. We have the interleukin 18. This is released by proximal tubular cells in response to injury, and they are detectable only in the urine. All right, it serves as an early marker of ischemic AKI, particularly in critically ill patients. So pathophysiology, how does AKI develop? Okay, number one is when there's glomerular dysfunction. Remember that the normal role of the glomeruli is to filter plasma, forming ultrafiltrate, primarily the urine. It serves as a selective barrier preventing protein and large molecules. But however, when there's a dysfunction of the glomeruli, that will lead to reduced GFR, all right? And with the reduced GFR, there will be retention of nitrogenous waste products, your urea and creatinine, and other substances that normally the kidney will excrete. So the first one is when there's a dysfunction of the glomerular, glomeruli in the kidney. The second one is tubular dysfunction. Remember the normal rule, all right? The tubules, both the proximal and the distal convoluted tubules are, very important in the absorption of water, glucose, amino acid, and electrolytes. All right, they are used also, in the concentration of urine through the contact current mechanism. So when there's a dysfunction of these tubules, all right, we have impaired reabsorption. This can lead to loss of water and electrolytes in urine. All right, inability to concentrate urine, leading to large volumes of dilute urine. So we have low specific gravity indicating poor concentrating ability, and this will also lead to electrolyte imbalance. In severe cases, we can have back leak of filtrate in circulation due to tubular cell damage. Then the other pathophysiology is increased salt delivery to the macula densa. Remember that the macula densa senses sodium concentration in the distal tubule and regulates GFR through the tubuloglomerular feedback. High sodium chloride normally with signant afferent arterial constriction to reduce filtration. However, in acute kidney injury or acute tubular necrosis, the tubular injury impairs reabsorption of sodium chloride in the proximal tubule. This leads to excess deposition of sodium chloride in the macula densa, leading to exaggerated feedback response. This will lead to vasoconstriction, therefore reducing GFR. Now, tubular lumen obstruction, necrotic tubular cells slough off into the lumen. All right, these cells, along with proteinaceous material, can form obstructive cast. This leads to increased intratubular pressure, which opposes your glomerular filtration pressure. The net result is a reduction in GFR, all right, which will also worsen renal function. So the clinical features of AKI, all right, resulting from all this pathophysiology, we can have the 3 A's and the 3 H's. So the first one is azotemia, which is a result of accumulation of nitrogenous waste, leading to increased urea and creatinine. And this is some of the commonest renal function tests we do. Usually it's asymptomatic, but may cause some neurological dysfunction or symptoms like confusion. All right. Then you have anuria or liguria when we have less than 500 mils of urine per day or less than 100 mil of urine per day. This may also present, remember that AKI may also present with non-liguric AKI. Acidosis due to impaired hydrogen ion excretion and bicarbonate reabsorption. This will lead to your cosmal breathing, fatigue, and confusion. All right, the H, hypokalemia with attendant risk of arrhythmias, and you can have other electrolyte imbalances like the hyponatremia, hypocalcemia, and hyperphosphatemia. Hypervolemia, this is due to sodium water retention, and this may also lead to increased peripheral or pulmonary edema. Hypertension will also ensue due to the volume overload and activation of the renin angiotensin system. Okay, for those of us that like mnemonics, also you can use I devours. All right, let's just put it devours. All right, and these also can be used as indications for renal replacement therapy. So it follows A-E-I-O-U, I-E-I-O-U. All right. So the A, anuria, acidosis, electrolyte imbalance, increased blood volume with consequent increase in blood pressure, oliguria, and uremia. All right, this makes it easy. If you can remember the 3 A's and the 3 H, you at least remember the vowels. Okay, so how do you make a diagnosis? Start with history and physical examination. History of recent illness, all right, sepsis, dehydration, medication use, all right, those who use NSAIDs, chronically ACE inhibitors, patients on aminoglycoside, your amikacin, and your gentamicin or tropomycin. Any urine output changes, exposure to contrast, or especially those who are going for contrasted examinations like your CT and all that, or trauma, recent trauma. Physical exam, you want to look out for signs of hypovolemia, signs of fluid overload, flank tenderness, bladder distension. You can talk about hypertension, or you look at, some examination that's suggestive of systemic causes like rash, joint swelling, and all that. So laboratory investigation, serum, urea, creatinine, they will be high, indicating azotemia. Electrolytes, your sodium, potassium, bicarbonate, calcium, and phosphate. You want to look at the blood urea, nitrogen, and creatinine ratio. This helps to differentiate between pre-renal, renal causes of AKI. You want to look at the urine, look at proteinuria, hematuria, all right, and cast. When you have a brown muddy urine, it points to acute tubular necrosis. Urine electrolyte like urine sodium is important, and there's molality. You want to also look at the arterial blood gases to assess your pH and bicarbonate for metabolic acidosis. Imaging is very important. Ultrasound, all right, is to rule out, to assess kidney size and to rule out obstruction. It also helps to differentiate between acute and chronic kidney disease. All right. Your kidney ureter bladder radiography is also useful for detecting radiopaque stones, which could be cause of post-renal AKI. CT scan gives you a detailed imaging of the masses, obstruction, and what have you. All right. Remember that no contrast is preferred because you want to avoid contrast-induced nephropathy. Retrograde pyelogram or our pyelography visualizes ureters, useful in ruling out obstructive uropathy. Renal Doppler, all right, will help, especially when you are suspecting renal artery stenosis or thrombosis. So we have other special tests, especially if you want to do renal biopsy, which is indicated in cases of uncleared renal AKI, okay, and it also provides histological diagnosis. So there are 4 phases of AKI as it develops, okay, 4 distinct clinical phases with each characteristic feature implications. So the first phase is the onset phase, or what we know as the initiation phase. This occurs between hours to days of insult, all right? Time from initial kidney insult to the onset of measurable renal dysfunction. This is usually as a result of decreased perfusion or direct tubular injury begins. Early recognition and reversal at this stage may help prevent progression of AKI and development of CKD. We have the second phase, the oliguric phase or the anuric phase, usually between 1 to 2 weeks, and it can vary. So here you will notice marked reduction in urine output with oliguria or anuria setting in. Pathophysiology of this phase is when there is severe decline of GFR, now less than 60 mils, all right? And accumulation of waste products, you see increased creatinine and blood urea nitrogen, fluid overload, electrolyte imbalance. Here you'll see edema, hypertension, or some uremic symptoms, especially uremic encephalopathy, all right? And because of increase in potassium, there's risk of life-threatening and arrhythmias from hyperkalemia or acidosis. Then we have the recovery phase, the diuretic phase, where this may take place between several days to weeks. There's a gradual increase in urine output, all right, which can be more than 3 liters per day. Here, the tubules have begun to recover, but remain unable to concentrate urine. So you see a very dilute urine. There's risk of volume depletion because of the diuretic phase, and the hyperkalemia and polynatremia may also occur. So here you want to monitor closely for dehydration and electrolyte loss. Then the recovery phase of AKI may take weeks to months, all right, where renal function begins to return gradually to normal, stabilizes. Then the kidneys regain the ability to concentrate urine. A lot of times we can have full recovery, but some patients may develop residual renal dysfunction and may progress to chronic kidney disease that require long-time renal replacement therapy program. All right, so these are the phases here. Okay, now quickly we'll talk about contrast-induced AKI before we talk about management. All right, especially those of us in ICU that usually request for contrast, CT, and what have you. So contrast-induced nephropathy is an iatrogenic renal injury which occurs after the administration of irradiated contrast media. All right, it is defined as an absolute rise in serum creatinine of more than 0.3 milligram per DL, or an increase of 50% from baseline within 48 to 72 hours after contrast exposure without any other identifiable cause. And this is important because contrast-induced nephropathy is usually treatable and reversible. So you need to be able, all right, to pick it up as early as possible. All right, it occurs in less than 1% in patients with normal renal function, but patients that have existing renal impairment, the incidence increases significantly. All right, so contrast-induced AKI, all right, patients with pre-existing kidney disease, diabetic patient, volume depletion or hypotension, patient with heart failure, patient who are on nephrotoxic drugs. And when you have high contrast volume or repeated exposures, patients who are age above 75, these are the risk factors for contrast-induced AKI. Or usually occurs within 24 to 48 hours after exposure to a contrast media. Like I said, generally self-limiting, lasting about 5 to 7 days. All right, most of the cases are not oliguric because urine output remains above 400 ml per day despite rise in creatinine and urea. All right, note that serum creatinine begins to rise within 24 to 48 hours after the exposure and peaks around 3 to 5 days afterwards. All right, usually returns to baseline within a week if no other complications occurs. All right, know that fractional excretion of sodium is usually low. All right, that tells you it's a pre-renal cause. Okay, how do you prevent it? This is important. Sometimes we need to make a diagnosis. For instance, you want to do your CTPA to make a diagnosis of your pulmonary embolism, and you want a contrasted CT. So what do? Hydration is the most effective prevention strategies. All right, you can give 1 ml per kg per hour of isotonic saline, all right, 6 to 12 hours pre and post contrast. All right, usually we use isotonic saline. And if you're going to use the contrast, make sure you use a low or smaller or as a smaller contrast agent and reduce the volume of the contrast. While you're doing this, you want to hold your nephrotoxic drugs before and after the procedure. Some people have advocated the use of antioxidants like your N-acetylcysteine, although it's controversial. But if you do have it, I recommend that it should be used in conjunction with proper hydration. All right, NSAIDs and AKI, we know this, okay? So renal function test, what are the functions, what are the investigations you look for? You want to test for glomerular function. And the first one is the GFR, all right? Okay, is the rate in millimeters per minute at which substances in the plasma are filtered through the glomerulus, all right? Also known as the clearance of a substance from the blood. So normally for an adult, it's between 90 to 120 ml per minute, all right? The second test for glomerular function is creatinine, which is the most commonly used endogenous marker for the assessment of glomerular function, okay? Creatinine clearance is calculated using this equation, all right? C is equal to U times volume, all right, urinary flow over the pressure, plasma concentration of the substance. Then blood urea nitrogen, all right, cysteine, like I mentioned before, all right, and the test for tubular function, electrolytes, your fractional extraction of sodium, once it's less than 1% is pre-renal, 2% intrinsic. You want to look at urine osmolality. Anything higher than 750 milliosmol per kg of water implies a normal concentrating ability of the urine. Urine as analysis, urine dipstick, and what have you. So the important thing is to prevent AKI from developing, okay? In the management strategy, you want to prevent AKI because of the high morbidity and mortality it carries. Like we said, mortalities can be above 50%, especially in critically ill patients. So the first thing is you want to identify high-risk patients early, then maintain adequate hydration, particularly before and after contrast studies or surgery. You want to avoid hypotension, ensuring adequate perfusion pressure, in sepsis and surgery, and you want to monitor renal function closely. Okay. Medication management, you want to avoid nephrotoxic drugs in patients who are at high risk. Okay. You want to adjust your dose. Okay. And as much as possible, use alternative medications. All right, complications. Remember the AKI harms, okay? So the complications of AKI, hyperkalemia with life-threatening arrhythmias, okay, hypertension, acidosis with anemia due to reduced erythropoietin production. You can have retention of fluid, metastatus changes, uremic encephalopathy, sepsis due to impaired immune function, and catheter-related infection, especially in patients requiring renal replacement therapy. So management, use KDIGO all the time, all right, for early recognition and monitoring. And you want to monitor your urea output, serum creatinine, and urea. You want to monitor electrolytes, especially potassium, acid-base balance. Continuously weigh your patient and fluid balance charting. Continuous intra-abdominal pressure, normal is less than 12, all right, between 12 to 20 millimeters of mercury intra-abdominal hypertension. When your intra-abdominal pressure is greater than 20 millimeters of mercury, it's abdominal compartment syndrome, all right? In all of this, make sure you rule out urinary retention from oliguric AKI, okay? So suprapubic, I've seen cases where a patient has been declared uric. Meanwhile, there's an obstruction, all right? There's urinary retention. The bladder is well palpable and painful. So you want to check for full bladder, check for urethral catheter, and bedside ultrasound helps you to look at the kidney. Okay, so confirm. The second one is confirm. Is this AKI pre-renal, renal, post-renal? And there are different ways you can do this, okay? From history, okay, and investigation, your urinary sodium, your fractional extraction of sodium, all of this will give you an indication of the type of oliguria, whether it's pre-renal or renal. Your blood urea nitrogen creatinine ratio, all right, greater than 20 will give you an insight into a pre-renal cause. So management is supportive. There's no management to restore kidney function in AKI. What we do is supportive most of the time. And how do you do this? Optimize fluid balance. Make sure your patient is fluid resuscitated, but also avoid fluid overload in patients who are oliguric. Hemodynamic support, make sure you maintain your MAP above 65 millimeters of mercury, and use vasopressor after adequate fluid resuscitation if need be. Adjust your calories and protein intake, and consider early enteral nutrition over parenteral. Identify and treat underlying causes, if it's sepsis, nephrotoxic, what have you, and avoid further kidney injury. Okay? Treatment. So we have the ABCDE checklist, okay, for treatment of AKI. Look at address drugs in patients with AKI. You want to look at your drug chart and either stop or do a renal dosing of your medications, okay? Always look at the medication, address them first. Patients on NSAID, aminoglycoside, and ACE inhibitors. B, boost your blood pressure, treat hypotension promptly, all right? The aim is to restore adequate renal perfusion. Calculate and correct fluid balance, all right? Monitor your input and output, daily weight and fluid status. Also ensure you avoid hypovolemia and fluid overload. D, deep urinalysis to look for proteinuria, hematuria, and sometimes, as indicated, you may want to do urine MCS. Exclude obstruction, okay? Ultrasound to check for hydronephrosis or post-renal obstructions. Catheterize the patient if you suspect bladder outlet obstruction. Okay, so correct and treat specific conditions, we talked about this. So quickly, let's look at the KDIGO guidelines of 2012. And I know it has been reviewed in 2023 without much change. So the guidelines or recommendations for AKI according to KDIGO is you must stage all AKI. I tell all the residents working with me, if you tell me a patient has AKI, I want to say, what is the KDIGO staging? You must be able to stage that because it's important to look at for severity. And severity will also determine, all right, whether you're going to use just supportive measures, you're going to commence this patient on renal replacement therapy. Number 2, determine the cause of AKI. Is it pre-renal, renal, or post-renal? All right. Test patient at risk of AKI to detect AKI. In the absence of hemorrhagic shock, use isotonic fluids, 0.9% saline, all right, or ringaslated for volume expansion, all right. Use vasopressor in conjunction with fluids. Note that diuretics are not recommended in the prevention or treatment of AKI except in fluid overload, as evidenced by pulmonary edema or cerebral edema. Low dose, note that low dose dopamine are not recommended to prevent or treat AKI. Aminopacosides are not recommended for infection except no suitable alternatives. Initiate renal replacement therapy immediately when indicated and discontinue when no longer indicated. All right, Gallagher guideline states that for renal replacement therapy, you want to use an uncuffed, not tunneled dialysis catheter. The right internal jugular vein is preferable. All right, the femoral vein, the left internal jugular vein, and less is the subclavian vein. Always ensure you obtain your chest X-ray after insertion of your central venous catheter, and use your continuous renal replacement therapy rather than intermittent hemodialysis for unstable patients, patients with acute brain injury, raised ICP, or brain edema. Okay, diuretic use quickly as we round up. Diuretics are often used in AKI to manage volume status, but note that they do not improve renal recovery or mortality. And the common ones we use are the loop diuretics. You want to avoid the use of potassium-sparing diuretics because they have no role in AKI. Okay, so these are some of the indications for diuretic use. Volume overload are not responsive to fluid restriction. Patient with pulmonary edema with preserved urine output. This is important. Urine output is adequate. Hyperkalemia as part of your combination therapy, all right, the management of hyperkalemia. And it's also useful to convert oliguric to non-oliguric AKI. Know that diuretics have no proven benefits, all right, in terms of survival or recovery, all right, may also cause ototoxicity, especially if you are using furosemide, electrolyte disturbances, or may also cause excessive diuresis leading to worsening hypovolemia. It's ineffective in patients with stable and uric AKI. Don't give furosemide to patients who is not making urine, all right? And over-reliance of furosemide may delay early initiation of renal replacement therapy. All right, dopamine, phenodopamine. Phenodopamine is a selective dopamine 1 receptor agonist, but it's according to Gadago, it has no place in the management of AKI. All right, I think we stop here next week because it's 2-in-1 lecture. Next week we'll talk more about renal replacement therapy. So let's stop here. I hope I've not too fast. I hope you followed me. If you have any question, please, the floor is open. Thank you. Did you guys follow me or was I too fast? Hello, are you guys here?
We followed,
Yes,
Prof.
Prof, we followed.
Okay.
We followed, Professor.
So any question, any contribution? Hello? I'll stop recording now so that we can discuss.